I was, trying to think. Dan already alluded to the election season in the United States, and was trying to think about an appropriate joke. And there just aren't any anymore. They've all, but it's 17 days, and this will be over in 17 days at least. Our long national nightmare, right, to quote Gerald Ford, when Richard Nixon resigned, I think, is where that comes from. So, okay, there we go. So first, just to start with a few introductory comments about clinical pharmacology, we really talk about three areas of study. Pharmacokinetics, that's the time course of drug through the body. We've talked about half-lives. We'll also talk about the spaces to which a drug penetrates, whether it's metabolized via the liver, is it cleared by the kidney. All those processes determine pharmacokinetics. And eventually then how much drug you have in the body. And that's then where pharmacodynamics comes in. The relationships then between the effects that are produced and that amount of drug in the body is the field of pharmacodynamics. And increasingly, pharmacogenetics is coming into play, those relationships between inherited traits, which can affect pharmacokinetics, may also affect pharmacodynamics. So the questions that I'm going to try to provide some comments on then are largely going to center on the field of pharmacokinetics. Talk a little bit about mechanisms and processes by how drugs are absorbed, how they distribute, how they penetrate into various tissues, what might be the effect of route of administration on that, physiologic, pathophysiologic issues, characteristics of the drug, and then if we want to try to enhance delivery into tissues, how might we do that? And finally, just a few things on drug-drug interactions. Professor DePerry will have a session later in this program that I think he'll say a lot more about that. Well, let me first start with drug absorption. So if we think about an oral drug when it is taken, the first process we are interested in is absorption, and that how much of that oral drug is going to get into the systemic circulation, and that's the process we call bioavailability. You'll often hear it expressed as a percent. 100% of the drug is absorbed, 80% of the drug is absorbed, and what that means is that's the fraction of drug that appears in the systemic circulation. Now, most oral drug is going to enter in the systemic circulation via the portal vein. But there are certain characteristics by which drugs can bypass the portal vein and therefore metabolism in the liver, and that can be via the lymph. And that may be of increasing importance as we think about at least gut-associated lymphoid tissue, lymph nodes, and whether the degree to which that's a reservoir or sanctuary for the virus. Well, one of the easy, classic ways to think about bioavailability is going back to the use of boosters, ritonavir or now cobicistat, and their effect on protease inhibitors. So this slide shows you what happens if you take lopinavir 400 milligrams without ritonavir. Very, very low concentrations, in fact, to the extent that it would not produce an antiviral effect. And when you give, even with a small amount of ritonavir in this single-dose study, just 50 milligrams, you dramatically shift the curve, and you affect two processes. You clearly get much, much higher concentrations, and this goes back to absorption or bioavailability. We're simply allowing more of the drug to be absorbed, to reach the systemic circulation, and that's because metabolism is being blocked. Now, there is also an effect of ritonavir on the half-life. You can look at this slope, and you can compare it with this slope, and see this is much longer, so indicating that metabolism is also being inhibited. Now, if you want, you can also think about this instead of a drug given orally, a drug given intravenously, and a drug given orally. This, for example, could represent a curve after an IV injection. This could represent one after an oral, where you would then see that loss of amount of drug that's available to be absorbed. Okay. Let me move now from absorption into distribution. This is a PET imaging scan of a quinolone trovafloxacin in humans. And if there's probably one point I'd like to make sure you walk away with about distribution, is that drugs don't distribute homogeneously throughout the body. Now, as clinicians, you really already know that, right? Think about the brain, right? You've got the blood-brain barrier. It is a protection against drugs entering into that compartment. And when you try to treat a brain infection, it can be very challenging to get enough drugs there. And there's many other compartments like that. Getting drug into the eye, back into the retina, getting it into bones, getting into joints, prostate. There's several privileged compartments, and this just illustrates that that point. This paper just recently came out in Nano Medicine, and if you're looking for one review article that I think does a beautiful job of walking through some of the issues related to drug formulation, trying to design drugs now to get into certain compartments, this is really a wonderful paper, and so I would refer you to that. So this figure now comes from that paper. And it's useful then to start the discussion about drug distribution and how different forms of administration, whether it's subcutaneous or intramuscular versus oral, may affect the amount of drug we actually get into the body. So you can start on the left-hand side of the slide with an orally administered drug. I already talked about the effects of first-pass metabolism affecting the amount of drug that gets in the systemic circulation. If you give, in this case, the authors are talking about administering drugs intramuscular or subcutaneous, and how particle size, how drug may then enter into the lymphatic system, how that may influence. You have now barriers. The drug has to transfer the blood, the lymph barrier, not one we talk about very often, but it's there just like a blood-brain barrier or a blood-testes barrier. At any rate, this shows you now some of the processes that are going to come into play as you start looking at giving drugs into the body differently. So let me try to give you an example of this. These come from two separate studies of dolutegravir in macaques, one when the drug was given orally and one when the drug was given subcutaneously. And so to just look at the first two that I've highlighted, in one case 2.5 milligrams per kilogram subcutaneously, 3.5 orally, and really you get very, very similar maximum concentrations, a little bit lower with a higher oral dose, and that may well be this principle of bioavailability. More drug is simply reaching the systemic circulation when it's given subcutaneously. So nothing horribly surprising here. But what is a bit more interesting is when you look at a trough concentration 24 hours later. At subcutaneous, you find really very little difference between that maximum drawn 2 hours or so after the dose was given and at 24 hours, where with oral drug, you clearly see much lower concentrations. So evidence here that how you administer, and this is not long-acting formulated drug, okay? Evidence that how you administer the drug may well affect this time course of drug through the body. Now that may be the case with long-acting formulations as well. So these are data from some of the very early studies, in this case in dogs, with the rilpivirine long-acting formulation, intramuscular injection versus subcutaneous administration. And here again, you can see evidence of two different profiles. With IM injection, much, much higher peaks than what you would achieve, or what was achieved when it was given subcutaneously. But a decay profile that looks much more like what you would expect to see after oral administration. In contrast, with sub-Q administration, as I've already alluded to, a lower peak concentration, but a much more sustained profile, again indicating this drug is entering into the systemic compartment in different ways than IM injection. Okay. Well, the point I want to leave you with is, and Ian, I think, alluded to, why long-acting drugs. This is not the first field to try to develop long-acting drugs. They're out for antipsychotics, for contraception, for several examples. And we've gotten pretty good at designing these formulations to achieve systemic concentrations that mimic what you see when you give them orally. And I think the data from the Latte 2 study are a good example of that. So these come from the Margolis abstract that was presented at CROI earlier this year, showing cabotegravir concentrations on the left, rilpivirine concentrations on the right. These solid lines here represent the trough concentrations with the orally administered drugs. And what you can see is, whether given every 4 weeks or given every 8 weeks, that the concentrations with these long-acting formulations are really very comparable. Not exactly the same, but really very comparable with what you would see when it's given orally. So to the question that was asked earlier is, are these formulations changing the amount of drug in the systemic circulation? I think the answer is no, not the way they've been formulated to date. They're really achieving very, very similar concentrations. Now, you can appreciate that they are running a little bit lower, and it's maybe most striking here with rilpivirine. For these first 16 weeks, these concentrations are lower. For both drugs now, the loading dose, or the first dose, is going to be increased in this phase 3 study. So with cabotegravir, the initial load will be 600 milligrams. For rilpivirine, the initial load will be 900 milligrams, and then they'll go into the usual every 4-week administration. And the predictions are that should help clear up these periods of lower concentrations with this formulation. Now, to try to get back to your question that you asked about, one thing I would add is, what we don't know is, while the concentrations look the same, the time course of those concentrations is obviously much different. And Dan talked about that, as well as it might relate to resistance. There certainly are drugs that can have cumulative toxicities. So it's not how high they are, but it's just how long. In some ways, amphotericin B has been kind of like that. The nucleosides and mitochondrial toxicity. There's some of the old nucleoside drugs where they just have to, if you take them long enough, you will accumulate enough damage to the mitochondria that you can see toxicity. Is that going to play out here? We just don't know. We've just not used them long enough. So, okay. But anyway, I think this, the point I'm trying to make here is, when we just look at concentrations in the blood, these long-acting formulations, I think we're going to be able to achieve the same type of levels with them that we can achieve when we give the drugs orally. Okay. Now to start talking about sanctuary compartments a little bit, I'm going to focus more on the lymph node. One, I guess it's because it's a compartment that we're working with, but it illustrates some of the same concepts about how drugs get into tissues, how they get uptake, how they distribute, and something we don't talk about very much, but may become of increasing importance, is retention. So drugs not only have to get in, to exert an effect, but they have to stay there long enough to do that. Here again, this is a figure from that nanomedicine paper I referred to, illustrating issues related to whether you have free drug, whether you have nano-formulated drug, and how long it's going to stay in the lymph node, whether it's going to leave very fast or going to leave very slow. Well, this is not new. You can go back into the very early literature with indinavir, the protease inhibitor, in this case given to rats, and compare the half-lives of the drug in plasma versus the half-lives of the drug in lymph, and you see this principle. Again, look at the differences in the slopes. Much, much faster in the lymph than it is in the plasma, indicating the drug was getting in. In fact, getting in very quickly and getting in concentrations comparable in lymph with plasma, but it was exiting much faster. So it was just not being retained in this organ. Well, why does that happen? certainly to some degree, it's the physical chemical properties of the drug. And probably the key ones that we think play a role here are going to be the molecular weight, the particle size, the log P or oxygenol to water partition coefficients, and long chain triglyceride solubility. So when we think then of how a drug might enter into the lymph, first, remember, just the differences in blood flow. Blood flow versus lymph flow is about 500 to 1. So there's a driving force already just to, move drug into the blood, into the portal vein. So that's a barrier right there. And then, drugs that have higher molecular weight have particle sizes that probably are in the 50 to 100 nanometer range. Drugs that have log P partition coefficients greater than 5 and greater long-chain triglyceride solubility, that's going to help preferentially move those drugs into the lymph. Nanoformulations are ways you can change physical chemical properties of the drug. These are data from Rodney Ho's group at the University of Washington, where he formulated 3 drugs, lopinavir, ritonavir, and tenofovir, into one nanoparticle, and in this case administered it subcutaneously to macaques. And if you compare plasma drug exposure to intracellular concentrations and now down into inguinal lymph node intracellular concentrations, what you see with with the nano-formulated drug is much higher penetration now into the inguinal lymph nodes. And that's because the nano formulation, it increases molecular weight. Rodney has paid particular attention to particle size in his study of nanoformulations, really trying to target that sweet spot in the 50 to 100 nanometer range, and they increase log P values. Now, tenofovir, and it's already been alluded to as much, nucleosides present challenges in terms of nanoformulation because of they're much more water-soluble drugs, so it's very difficult to package those into formulations. There's actually a lot of work in this field now, and I think there's some new ways emerging that may help overcome some of those challenges. But this is not the only way by which you can potentially have a formulation with that can gain greater access into certain compartments of the body. We have, I think, what looks to be a really good example right now with tenofovir. These are data with tenofovir disoproxyl fumarate, or the alafenamide, given to dogs. And here you can compare lymph node concentrations, 15-fold greater when given in the TAF formulation than when given in TDF. So this compound, because of a different side chain on it, seems to have preferential lymphatic tissue penetration. That, it doesn't solve necessarily all problems, however. You can jump down here to the brain, and neither one of these formulations are penetrating into the CNS, very well. But nonetheless, it illustrates a role of formulations in trying to help you get drug where it is you want it to go. Now, we've talked then a bit about formulations. We've talked a little bit about physical chemical properties. Those probably aren't the only factors that are going to affect the spaces to which drugs distribute. When we talk about the nucleosides, but as well protease inhibitors and integrase inhibitors, we're learning that these drugs are not only substrates for drug metabolizing enzymes, but they're substrates for membrane transporters that control both influx and efflux into certain tissues. And these are data from a paper published earlier this year looking at testicular tissue that is very rich in membrane transporters. And really honing down into 3 MRP1, breast cancer resistant protein, P-glycoprotein that you've heard a lot about, and finding that MRP1 in particular was highly expressed in testicular tissues. We then were able to work with this Rena Bendayan and this group from Canada, looking at 5 males who were undergoing gender reassignment surgery. And so we had the ability then to study the testes, looking at the expression of these membrane transporters and the antiretroviral drugs that they were on, and the penetration in plasma and in tissues. And I'll just make the point with darunavir, we find about 15% of the drug in testicular tissue, as we find in plasma. And darunavir is a substrate for these membrane transporters, I think, indicating a role of these transporters in preventing drug from accessing this tissue. So whether drugs are substrates for these transporters and the extent to which they're expressed in different tissues may well be a factor that affects penetration into sites. And the final thing is just maybe a bit about pathophysiology. Tim Schacker's group at the University of Minnesota has long studied lymph node fibrosis and collagen deposition. This is just a figure from one of Tim's more recent work, looking now across HIV-infected persons, including elite controllers, comparing them with uninfected, and finding changes in the lymph node architecture. Well, if flow is important, if blood flow, lymph flow is important in getting drug to an organ, if fibrosis, so a pathophysiologic event related to HIV infection, begins to affect that, is that then going to influence penetration of drug into these tissues? This has not been studied, but I think it's a reasonable hypothesis for someone to explore. So to try to wrap this up is the field of residual viral replication is alive and well with a variety of opinions. These are data from a Nature Methods paper published in 2015 that I thought was really some beautiful methodologic work. In this case, looking at macaques, SIV infected, treating them with conventional antiretroviral therapy, finding that viremia was suppressed, but then using this whole body immunopet probing, and finding that there was residual signal for viral replication in the colon, spleen, male genital tract, and in individual lymph nodes, organs to which these drugs are not going to penetrate to the same degree that they penetrate or that they reach plasma. And so is low drug concentrations what is allowing replication to exist in some tissues, even though someone has suppressed virus in the plasma. I think Ian, Dr. McGowan said it very well. More drug gives you less virus, and so with that, I'm actually going to allude to some of Ian's work. In fact, really, I think, elegant paper just published online, Lancet HIV, mid last month, looking at compartmental differences with rilpivirine when the long-acting formulation was given. And so it's always a little risky to be quoting something from a speaker who's here and has already spoken. So if I get something wrong, just jump right in, just be nice, right? So, but what you can see here when you look in this light blue line here, this is plasma concentrations, and then you have vaginal fluid concentrations, endocervical concentrations, and rectal fluid concentrations, clearly indicating differences among these compartments in terms of how much drug is in these fluids. And the same thing you see with tissues, now rectal tissue concentrations and the cervical and vaginal tissue concentrations here. So these compartments are not all behaving in the same way, and it's that principle of a lack of homogeneous distribution of drug throughout the body. And Dr. McGowan's already alluded to, with the explant infection model, evidence for a relationship then between increasing drug and a decreasing amount of virus in rectal tissue, but not being found in vaginal, in vaginal tissue. And is this then driven by the fact that you don't have the same amount of drug present? Okay, let me shift in and in with just a few things about drug-drug interactions. Again, this will be talked about later. These, the integrase inhibitors, protease inhibitors, we know there are drugs that are metabolized via the liver, and that makes them susceptible to concomitant therapy that is going to affect hepatic drug metabolism, and that's going to be true whether these drugs are given orally or whether they are given in long-acting formulations. We don't yet, unless someone out here does, have a way to engineer these formulations to completely protect them from drugs that affect hepatic drug metabolism. But Professor DePerry may want to comment on that if he thinks otherwise. So here's a study, for example, with cabotegravir with rifampin. Rifampin, is one of the most potent enzyme inducers we have. When it's given orally, you see the concentrations in the green line. When it's given orally with rifampin, you see the concentrations in the blue line. So decreasing area under the curve a little bit more than half. So rifampin with oral cabotegravir would be contraindicated. Rifampin with cabotegravir long-acting is going to be contraindicated as well. There's no reason to think that you won't have the same type of potent reduction in concentrations if you give the long-acting form with rifampin. And to just make the point that these drug interactions can be clinically significant, these are data from Kim Scarzy, published earlier this year in Clinical Infectious Diseases, looking at the levonorgestrel depot implant. This is a product that's designed, to provide high levels of protection for 4 to 5 years. And efavirenz, it to be a potent enzyme inducer, and it's exactly what was seen. ART-naive patients, the nevirapine group, and then this is the efavirenz group. So somewhere between a 50 to almost 60% reduction in concentrations, and in this group of patients, small, but nonetheless 15%. So 3 out of 20 of these women had unintended pregnancies. So that's a failure rate that is just enormously higher than what you would ever expect for the hormonal implant. So indicating that no matter how you give it, if a drug is susceptible to drug interactions, they can still be there. So to wrap up a few things, our knowledge then of, when we start talking about sanctuary sites, our knowledge really is rather poor about what are the most important factors that are going to determine penetration into a space like the lymph nodes, like testes, like the brain. We know some of the factors are going to include physiology. We know they're going to include physical chemical characteristics. We know they're going to include pharmacologic characteristics. But what's the most important? How these come together. If we affect one, can another one, become more important? It's just not well known yet. What I'll try to leave you with then is how I think as a field we're merging to have to think about drug penetration. And when we just talk about concentrations in the plasma, we've gotten pretty good about thinking about all those things that can affect it. Intestinal absorption, intestinal metabolism, liver metabolism, that can all influence the final amount of drug we get in the plasma. What we have not gotten good about yet now is thinking exactly about what's happening at the target, at the space we need the drugs to go, and that's where we're going to have to improve. What about tissue distribution and blood flow or carrier-mediated, these transporters, the genetic expression of them? What about the cellular distribution, membrane permeability? I mean, remember, if we're dealing with highly protein-bound drugs, it's only that unbound moiety that's going to be able to move across membranes and penetrate into those sites. And then finally, at the target site, transport and trafficking, the expression of the target, and ultimately getting here to tissue or cell availability. So moving from just systemic availability into tissue and cell, I think is where the field will need to go. So with that, I'd like to say thank you. It's really been my privilege to be here, and happy to try to take a few questions now, but I'll join the panel as well.
So questions to Courtney. Dan here, microphone 1.
Courtney, that was great, and thanks for filling in all the details that I glossed over. The one question, because you showed this figure from that review article of how drug flows through the lymph node. It's my understanding that with the long-acting formulations that we're talking about today with Cabo and rilpivirine, even though they are nano-formulated, that it's free drug as the solubilized small molecule that is diffusing out of those particles and then circulating, different from other therapeutic interventions which are delivering drug as a nanoparticle. Is that correct?
It is, Dan. So and it's a good point, and one that allows me to remind everyone that the conventional development of long-acting formulations has been to achieve a long half-life in the plasma, so that you don't have to give the drug as long. And so think about the antipsychotics that are out there. The paliperidone now that you can give once every 3 months or so. That's been the conventional focus of a long-acting formulation. It's not been to try to target it to a certain tissue. And so folks have not paid as much attention to some of the issues such as particle size, such as long-chain triglyceride solubility, and those things. So in the review article that I mentioned and in some of the formulations that particularly Rodney Ho at Washington's trying to develop, Rodney's now doing that. So trying to make them not just have long half-lives, but preferentially target that compartment. So when you look at the particle sizes, Dan, for like the long-acting Cabo, the long-acting rilpivirine, and Ian, correct me if I get it wrong, I think they're in the 200 nanometer size, so larger than what, it doesn't mean they won't get in, but larger than what may be that sweet spot for lymph node, not just penetration, but then being retained in there long enough. And always remember with these nano, the drug's got to be released. So, that becomes another issue. Is the drug now able to come out of these particles that have been formulated and distribute within that tissue?
So microphone, the number 1, Francesca.
Thank you. Thank you. Really excellent talk. You spoke about the fibrosis in the lymph node that can influence the entrance and the maintenance of the drug in the lymph node. What is known about the liver metabolism regarding the fibrosis and cirrhosis in the liver? How can influence, because we are speaking about this a lot for hepatitis C drugs. What is known about HIV drugs? Yeah, well, it's a great question. In terms of just drug metabolism itself, that is a process that is just very, very well conserved in the body. And I may pick on some of the other pharmacologists I see in the back of the room, Gianni or Say, but it takes very, very advanced liver disease before you really start to see profound changes in being able to metabolize the drug. Now, in terms of tissue concentrations, I've not seen any work on that, and if anyone has, boy, don't hesitate to jump in to see whether, in that case, you can, if you get the drug there, you can metabolize it, but are you able to get the same amounts of drug there? So you'd have to do, liver biopsies to look at that. There certainly have been some, biopsy work, but I've not seen anyone that has a large enough, amount of data to say whether those tissue concentrations now are different if you're in, early stage HCV or late stage with a lot of fibrosis.